afternoon. I'm Sean Murphy. I'm an associate professor here in the department, and I'm sorry that I can't be with you today to celebrate the third Gottfried Schmier Memorial Lecture. Before Dr. Citrone is introduced, I'm going to take a few minutes to remember the life and legacy of Dr. Gottfried Schmier. Dr. Schmier trained in medicine and served as a general practitioner in Austria in the 1950s, and then returned to the University of Vienna to study biochemistry. This ultimately led to our good fortune when he came to Seattle in 1967 to work with Hans Neurath and Earl Davy in the UW Biochemistry Department, where he focused his work on coagulation. He isolated von Willebrand's factor and the factor VIII complex in 1970, and he was recruited by our founder, Paul Strangert, to join the UW Laboratory Medicine Department, where he served as the chief of clinical coagulation from 1970 until 1998. These are a couple of his very important papers in the Journal of Biochemistry, Journal of Biological Chemistry, focused in particular on factor VIII. And then he retired, kind of. He said the real adventures in his life started with his retirement on June 30th, 1998, when he decided to dedicate the years he had left to the impoverished population in the tropics as a volunteer physician. And to do this, he did a lot more training. He took the master's program in public health and tropical medicine at Tulane University and graduated there in 1993. And in 1997, he was awarded the Tropical Medicine Certificate from the American Society of Tropical Medicine and Hygiene. And with this training, he went first to Peru, where he worked in the Altiplano. And later he went to Manaus in Brazil, where he worked with someone he greatly admired, the great leprologist Sinesso Talhari, who still practices there. And in Brazil, he would go on medical expeditions on the Rio Negro and Rio Amazonas rivers, where he cared for patients with malaria, leishmania, leprosy, and other infectious diseases. And he did this from the late 1990s until 2016. When he came back, he continued to provide care for patients at Harborview, where he attended until 2016. And he rode his bike to work into his 80s, all the while speaking 5 different languages. When he was in the Amazonas, he would ride around in these riverboats, which he had a love-hate relationship with because it was far too hot and muggy for him. But he made a really tremendous impact there, and he made a really tremendous impact on our department in all of the teaching that he did throughout the years. He taught me and countless other undergrads, graduates, and other resident fellow trainees about coagulation, about tropical medicine, and certainly about life. We are very grateful for his contributions and are very happy to have Dr. Citrone here to give the third lecture. So let me turn it over to Dan Sabath, who will introduce today's speaker.
Okay, well, that was lovely. And I just need to say, I knew Gottfried Schmier, and I used to encounter him on the Burke-Gilman Trail, so I can vouch for the fact that he rode his bike to work every day. He taught me coag, and I believe he spoke 8 languages, but I could be wrong about that. But he definitely had a little dabbled in Japanese, so I know there's at least one more. Anyhow, it's my pleasure today to introduce somebody else who I've known for a while, and that is Dr. Marty Cetron, who is our Gottfried Schmier lecturer for today. And I've known Marty for a little while. We both came to Seattle at the same time, and I won't mention what year that was to spare us both, but Marty came here as an infectious disease fellow, and I came here as a pathology resident, and we had some mutual friends, actually, from some friends of mine from my summer camp, actually, who knew Marty from medical school, and so we met each other that way, and we had a number of good years here. Marty was an ID fellow. We did a lot of skiing, we did a lot of hiking. Some of these shenanigans also involved people like Brad Cookson and Chihiro Morishima and Chuck Murray, who some of you know. So that's sort of our personal connection, goes way back. And then Marty left here, sadly. He went to Atlanta, and then he spent really his entire career at the CDC. And he had a number of responsibilities there over the years. I remember him being heavily involved in things like respiratory diseases and pandemic, or not pandemic, but like outbreaks on cruise ships, if I recall, at one time. And, you know, this the usual CDC stuff. His current official title is Director of the Division of Global Migration and Quarantine, at least until he kind of officially goes into, well, I guess whatever his next career will be, shall we say. And anyway, so he's obviously been at the CDC through a very interesting time over the last number of years. And so I will shut up now so that Marty has enough time to talk to us. But it's really just a pleasure to see him. I wish he were here in person, and I'm trying to convince him to come visit in person for my own personal benefit. But anyways, without any further yakking, Marty Cetron, take it away.
Thanks, Danny. Thanks to you and Sean and Brooke for the kind invitation. And it's really an honor to give a memorial lecture to Dr. Schmier, who, in fact, I tracked my career in tropical medicine and infectious disease, you know, in similar paths and crossing similar roads in countries that he did. While he did it in retirement, it sounded like he had a really robust retirement. And just to make a minor correction, I stepped down as the Director of Global Migration and Quarantine a year ago or so, in June 1st of 22. And as just a few moments ago, I saw the announcement that my successor has been named and will take over the helm, and my deputy has been acting in that role. So I'm really honored to give this. I'm going to share my screen and switch over, and I'll show you some of the disclaimers and so on about this. Let's share and go that way. And hopefully you can see the slides, and I will, this is the notes about the presentation. Everybody's muted by default. Please use the QA function to ask questions, and Danny will read submitted questions after the presentation. In addition, whoops, I want to make this disclosure. I have not had any financial relationships with ineligible entities over the past 24 months. And the views and the content that I'm going to present today are my own, and they don't represent official US government, HHS, or CDC positions. I just wanted to be clear about that. So with that, I'll move on to this presentation. And the title of my talk is Pandemics, Syndemics, and Permademics, Are We Ready? Looking at microbes, hosts, and society, and trying to anticipate what the future holds for us. As I said, I'm the former Director of Global Migration and Quarantine, and by the end of May, I think the new permanent director will also be in place. So as an overview, I'm going to review some things about pandemic dynamics, help you understand and define syndemics, the impacts that pandemics have, some of the current status of the COVID permademic, as I like to call it, the successes and challenges briefly, but also end with a note on a path forward from my perspective of having been in infectious disease outbreak control and pandemics and epidemics for now 31 years. And I also want to highlight the critical aspects of health equity, health security, and health justice, which I think this pandemic really revealed enormous challenges. So for me, in infectious disease, we like to say that my perspective is pandemics are like the holy triad. It is not just about the pathogen, it's not just about the host, and it's not just about the milieu or social context, which is why I went into public health, but it's the intersection of all of those things. And understanding how pandemics affect humanity, one needs to be able to have an eye on all three of these factors at the same time, because it is that perfect storm in which emerging infections and pandemics happen. And some photos to give you a feel for what that intersection may look like. So in 2020, the lexicographers coined a word of the year as lockdown. But in 2022, the same lexicographers from the UK-based Collins Dictionary declared permacrisis was the word of the year for 2022. And they defined it as living in the state of permanent crisis an extended period of permanent instability and insecurity, like periods of war, inflation, economic disruption, and political instability. And certainly if you look at the world around us today, there are many features that have earned 2022 this ominous title. This sort of inspired me to answer the question that I've been asked almost constantly throughout the 3 years of the pandemic, which is SARS-CoV-2 and COVID disease still a pandemic, or is it endemic? Are we reached herd immunity? Does herd immunity apply? And how do we understand these pathogens? And I would have to answer that we need a new word, because it's more like a permademic. So I coined this term after reading about permacrisis. And the way I define it is pathogens with ubiquitous presence across the globe that fluctuate in this cyclical nether region between endemic and pandemic state. Largely, this is characteristic of pathogens which have a large zoonotic or animal reservoir. In that space, these pathogens, in addition to a large zoonotic reservoir, these microbes retain their evolutionary ability to oscillate and adapt to this changing environment, and they may cause periodic local, regional, or global outbreaks. And so examples are shown here. The SARS coronaviruses, SARS-CoV-2, Ebola, Mpox, and influenza all sort of fit this characteristic because of their very large zoonotic reservoir and their ability to adapt in their environment, none more so than SARS-CoV-2. They can constantly come back and create outbreaks, whether it's because of waning host immunity or whether it's because of evolving evolutionary characteristics of the virus itself. And I think there's a number of pathogens that will represent pandemic threats and that we're going to have to constantly watch for their permademic potential. But I don't think we're really going to see the end of SARS-CoV-2, even as we acquire and build up an immunity wall, whether from natural infection or vaccines. So permademic is something to keep on your mind. Then if that's what a permademic is, what's a syndemic? Well, a syndemic, and this is not my term, but I've sort of written down here the way I think about syndemics, is these are concurrent phenomena or contemporaneous phenomena, which through synergistic action can potentiate and accelerate the scope, the speed, the impact magnitude of individual crises or a pandemic. And so they play out by existing in the same times and places. They can lead to this constant state of permacrisis. The COVID pandemic, its economic disruption that it causes in the setting of global warming and climate change, which forces mass migrations, as do the violence and political upheaval and periodic areas of famine and malnutrition. These things all coexist contemporaneously and create syndemics, each of them making the other more challenging. In particular, managing the COVID pandemic over the last 3 years in the setting of mass migrations, in the setting of evacuations from Afghanistan, in the setting of the war in Ukraine, with political upheaval, the challenges between autocracy and democracy, all of these things, and the economic impact and devastation of COVID, all of these things make it harder to deal with each one of them individually. So let me talk a little bit about what the characteristics of this pandemic, syndemic, permademic dynamic looks like. And I'll be focusing a little bit in particular on COVID. It's the perfect storm of microbes, hosts, and society. What I've seen over my time at CDC, and if I look historically, and we did a lot of historical research of the 1918 pandemic that was published during the Bush administration in the early noughts. What I see is a pattern where pandemic, syndemic dynamics have become more frequent. That is to say, the time interval between them has been decreasing. They've become more intense. They last longer in duration, and their geographic scope can be much more significant, and they can have greater impact. They're also moving much more quickly at scale and at speed in a way that makes it very challenging to keep up with the microbe. In fact, the microbe is often able to move faster and more with wider geographic variability than our human systems and institutions have been able to keep up with. And so we're constantly playing catch up and battling, in the rearview mirror as the pathogens and the pandemics come to bite us from behind. And we need to be able to get ahead of that. The other thing that's very clear to me is that each of these successive permademics and pandemics have caused much greater global social disruption that goes well beyond the health sector. And as a consequence, the coordination that's necessary between public health perspective and the healthcare systems perspective, along with the political dynamics, the private sector and the economic concerns, and the population's perspective and understanding are absolutely critical in terms of battling future pandemics and syndemic events. Let me give you some example by starting with where we are. This is at very recent data from the WHO health emergencies websites for tracking data. And what you can see from this dashboard, as of now, we've had almost 800 million confirmed cases of COVID that have been reported. Undoubtedly, there are much more based on seroprevalence studies, and nearly 7 million reported deaths that have come to WHO. As of April 24th, there have been over 13 billion vaccine doses administered. In looking at these numbers, I'm reminded that it was only 2 decades ago, 2003, where SARS-CoV-1 emerged, and it lasted 3 months, not 3 years. It caused about 8,000 cases, if I remember correctly, and about 800 deaths. These are orders and orders of magnitude different than what we are now facing 20 years later with SARS-CoV-2. So I know people have said this pandemic is like something we haven't seen in 100 years, and maybe we won't see it again for 100 years. But I would argue that that's unlikely. If you look at the epi curve, and I know the axes are hard to read, I want to mostly show you the shape, is these 800 million confirmed cases are just probably the tip of the iceberg. But in fact, what happens is we are seeing waves of this virus move through, both because of variants emerging in the virus, but also because of lack of widespread population immunity, and even despite vaccine. And we are still seeing a huge number of deaths. And although the waves look like they're attenuating as we build up our immunity wall, either from natural infection or vaccine-induced immunity, many people have required multiple doses of vaccination over the 2 years of the pandemic that it's been available so far. So this represents quite a challenge, and it also makes us rethink the concept of herd immunity. For many viruses, they're not that mutable, and the immunity that is generated by vaccination doesn't wane in a matter of months, but is durable for either a lifetime or certainly potentially a decade. And this is a fundamental difference in that regard. Let me talk about the impact factors in terms of the beyond health. This is a really sobering slide, and if I had only one slide in terms of the heads up, this would be the one to think about. The broader effect on societies. 90% of healthcare systems have been disrupted by COVID. And the economic impact is estimated now, just in the international trade arena, is estimated at $16 trillion. 1.6 billion students were out of school. We've set back our investments in clean energy transition by 30% less in ability to invest. And global poverty has expanded and pushing an additional 135 million people into poverty by 2030 is estimated. So what we can see is this is not just a health crisis, although it is a major health crisis, and healthcare systems around the globe have really not been up to the task of dealing with the whack that this virus has given us. But if you look over here, the economic impact alone of this outbreak has so far outstripped any of the previous ones just in the last, since the turn of the century, since the turn of the millennia. And what we see is that compared to SARS-1 in 2003, if the baseline is the global economic impact of HIV, TB, and malaria as a economic cost to the planet, that was 145% above baseline, but the COVID-19 pandemic is estimated to be at least 40,000 times more significant in that regard. So I hope this gives you that point. Why has this happened? We have a virus which in so many ways has been unprecedented in my experience in infectious disease over the last 30 plus years. Part of it is that it's highly, highly transmissible, one of the most transmissible viruses on the planet. Part of it is the fact that it has its peak transmission very early, as opposed to very late when people are too sick to move. And so there's a lot of mobility during an infectious period. Part of it is that it has such a wide symptom array that it's the great masquerader, as they used to say about syphilis. Part of it is the fact that it is one of the most mutable RNA viruses that we know. And here's just a sense of some of the incredible mutations that this virus has undergone in the short years of the pandemic, including recent mutations that are very immune evasive. And they've been evading our therapeutics, like Evusheld in terms of monoclonal antibody treatments. They've been evading to some extent changes in our diagnostics, and they've been evading the impact of our vaccines, at least in terms of sterilizing vaccination to prevent infection and spread. Fortunately, the vaccines are still holding up, probably a lot because of cellular immunity, not because of waning humoral immunity. But we're seeing both big, what we call in the influenza world, big shifts in the emergent variants of concern, in addition, constant drifts with sort of daughter-like offsprings. The predominant strain that's circulating in the globe and the US right now is in XBB.1.5, but there's an emerging XBB.1.16. And these emerging variants have proven themselves more infectious, more transmissible, and in many ways more challenging in terms of our therapeutics, our prevention, and in some cases even our diagnostics. So Omicron is like almost an entirely new virus with so many mutations over wild type. And folks will remember Omicron in 2022 or 2021, really taking over rapidly in the globe, around the Thanksgiving time. So we're seeing these two types of evolution, the lineage, sublineage variant, but also big shifts from alpha into beta, delta, gamma, and then more recently, sort of the Omicron variants and its sub things. So in November 2021, Omicron emerged in a setting of high population immunity. So despite the fact that many people had infection and many people were vaccinated, Omicron really took over the globe, and within 6 weeks had an almost uniform spike across all the countries on the planet. Extremely transmissible with immunoescape, and it replicates better in the upper respiratory tract compared to Delta or the index virus. We are fortunate that from a severity perspective, it's caused more upper infections than deep pneumonias. And so to that extent, we were very fortunate because it was incredibly pervasive in transmission. So that's just, the COVID story. The risk, it won't be the last health emergency that we face, to be sure. And during COVID, many concurrent emergencies and pandemics have occurred, including Mpox and other, viral threats. Now, this factor plays into the increasing humanitarian crisis needs, where 160 million people are targeted by health clusters across 56 countries that involve major humanitarian crises and displacement. We also have all those other factors, and this is what lays into the syndemic part of my perspective. So let's just review a few of the successes, some of the challenges, and some of the opportunities that lie into the path forward. I would say that a success that we weren't sure would be one, we weren't sure it would happen, and certainly it's a mixed blessing, is that when the virus emerged, the non-pharmaceutical interventions, or sometimes called the public health and social measures, NPIs and PHSMs, actually proved themselves to work. The data which was supportive of that were some research data that many people were involved in, and our team studied the 1918 pandemic in great detail. And in modeling, it looked like this should work, but we were talking about the 21st century, not the early 20th century, and whether that would hold up, whether you could use social distancing, masks, school closures, business closures, all the kind of NPI things to buy time or not, was not clear whether that would have an impact on transmission. And we really did see that impact. Now, it was never meant to be permanent, but decreasing the transmission, as I'll show you, was meant to buy time and offset other benefits for countermeasures to be developed and come back. We saw the relatively rapid development of PCR and antigen test diagnostics, although it got off to, admittedly, a very slow start, and we were left blind far too long. And then we moved into this era where we really expanded our genomics understanding of the virus, and whole genome sequencing, deep genome sequencing, really gave us a very important tool to understand the mutability of this virus and try to stay ahead of it. Also, no one can argue that Operation Warp Speed, bringing a vaccine to market in under a year, built on a platform of 10 years or more research in mRNA vaccine platforms, was a remarkable accomplishment. But this too, had its challenges. The vaccine in a vial doesn't save lives. It's vaccines in arms and getting good coverage and getting the right target populations at greatest risk to be protected by vaccine. And we've still had a lot of challenges in that space. Other challenges I've listed here, I'm sure many of you are well aware of. We have not well integrated data systems. We have healthcare infrastructure that is really teetering on just in time delivery. The communications in our data systems between the healthcare sector and the public health sector and other places is woefully incomplete. Our global surveillance is limited and not as well coordinated as it needs to be. The viral evolution challenges have been among the greatest, as well as the characteristics of the virus that I mentioned earlier: asymptomatic transmission, pre-symptomatic transmission, constant immune evasion at rates that we have really not appreciated before, weakened infection prevention and control systems, healthcare delivery systems globally that were just not up to this challenge, a lack of cohesive global policies. And what we're really seeing right now is a tremendous amount of COVID fatigue and the collateral damage of having been in this pandemic for 3 years. Where are the opportunities? I think the biggest opportunity that we have is we need to change the pandemic narrative. The communication and the narrative about this virus and the pandemic, learning as we go and trying to adapt, has been woefully inadequate compared to the narratives of disinformation or false dichotomies. We have an opportunity to build technology and other systems that can operate at the scale and the speed of the virus and be more proactive instead of reactive. We must actually look at the things that erode public trust and try to rebuild public trust in institutions, public trust in communities, in leaders. This is a really difficult area, but you can't build public trust in the middle of a crisis. You need to build that in advance. And so there's a lot of work that needs to be done in this area. And finally, this pandemic, like many other types of health crises, have painfully revealed our health disparities, the lack of health equity, the lack of health justice. So let me show you some examples of those things. This is the document we published in 2007 in the US government's pandemic planning guidelines. And it basically said that until we have countermeasures, we're going to have to rely on non-pharmaceutical interventions. In fact, we coined that term back then, where essentially we would have a pandemic outbreak that if it spikes acutely without interventions, it's likely to exceed the capacity for us to respond. And so one of the goals was to delay disease transmission, mitigate it, and shift the outbreak curve to the right. In addition, we wanted to decrease the peak to get a curve that looked more like this so that the case management and the hospitalizations could be within the reach of the healthcare system to deliver necessary supportive care. And when you do that, you actually reduce the area under the curve. The overall number of cases and the overall deaths should go down. This is exactly what happened in 1918 during the influenza pandemic. We studied 43 cities across the United States with large populations, and we found that there was huge variability in how in the death curve of the pandemic over a 6-month period, based on some that had a very high peak spike like Philadelphia versus others that had a more gradual set of humps like St. Louis. So the idea is basically to flatten this curve and mitigate the effects while you buy time for medical countermeasures. It looks like the video of the social there it is. And this is the theory. It turns out that this worked. We saw this happen in the first year of the pandemic while we were waiting for the science to catch up, the vaccines to be developed, for better treatments to come in, and for clinicians to learn how to manage and care for these very sick patients in their hospital. But this is sort of the goal of non-pharmaceutical interventions. And it was based on models, and it was based on 100-year-old historical data, but it turned out to be true. Right now, our current situation in April, this is a WHO map again, that shows that this is the status of non-pharmaceutical public health and social measures, NPIs, across the globe. And you can see mostly everybody has reverted to either nothing in the candy stripe or the least restrictive types of measures. So people are generally across the planet are sort of over this. The governments in many ways are over this aspect of it, and the great unmasking of the globe has occurred. And so we're no longer in a place where these are tolerable, acceptable, but we're 3 years in, and we have a lot of medical countermeasures. Question is, are we using them? So as of today, I think I've showed you the data on confirmed reported cases and deaths, cumulative deaths. But what we see, just like in the 1918 study of cities in the US, we look regionally and we can see large variations in the burden. And this is weekly case reports by WHO region. I'll show a little bit more of that later. But not everybody, not every region experienced this pandemic in the same way. And some use non-pharmaceutical measures for a much longer period of time. The most illustrious is China's approach to zero COVID, where things were really locked down for a long time. Unfortunately, it took longer for them to come back with really powerfully effective vaccines. And so they had a very recent large spike that generated a lot of natural infection-based immunity. But the idea of coming in with really effective vaccines early on is an important part of the strategy. But there's a lot of variability, and we would do well to study the lessons of comparative country policies and responses to see what really works well and what doesn't. This is that variability shown even more keenly in terms of deaths. These are weekly reported deaths by the WHO region, and you can see the Americas did not perform well. This is total number of deaths, not adjusted for population, but adjusted for population, we still don't perform well in the Americas region, with about 3 million cumulative deaths and over 1.1 million reported cumulative deaths in the US alone. So the impact of our ability to respond to COVID and reduce mortality, and that's not even taking into account morbidity from long COVID, has been extremely variable. Now, these y-axes are different to account for the amount. So this is up, peaking at 40,000, this is 30,000, this is 4,000. Some of this could be surveillance and reporting artifact, but I think a lot of it is actual real differences that we would do well to be able to study in detail, not in a political debate or battle or finger pointing, but really a learning process to figure out how we can better prepare what worked and what didn't work. And here's just an example these are the top 12, I think, listed countries where the cumulative death toll was the greatest. Unfortunately, we have that sad experience in the United States of being at the top of this list with 1.1 million reported deaths, and largely that's a significant underestimate. Vaccines were another huge success. This is vaccination, which is global vaccination, has exceeded 13 billion. And this is data showing a map adjusted for the vaccine doses administered per population, per 100 population. But what we can see is there's still a lot of variability and a tremendous amount of inequity. And if this weren't April of 23 data, we would see a huge disparity in the timing with which those vaccines became globally available, despite COVAX and other efforts. So the experience of not only getting vaccine, having vaccine available, getting it into arms in a timely way to avert deaths is significant. So what do I mean about the changing the narrative? We can look at the pandemic from at least 4 different lenses: the public health lens, which is necessary but not sufficient; a private sector lens, particularly on the economy; a political lens in terms of the leadership; and a population lens. And in each of these cases, I would argue that what we experienced was a set of false dichotomies that led to tension between each of these groups, everyone blaming somebody else for why we were experiencing this whole of society problem. The private sector blamed public health for interrupting the economy. The two political, in the US for sure, the political parties were constantly figure pointing, and either one claiming the other overreacted, the other claiming that there was an underreaction. And no doubt there was just a constant tension in this narrative. And the population, notably confused by mixed messages and communication challenges and in cognitive biases and cognitive dissonance in being able to understand the message that scientists were trying to communicate, or public health figures or government leaders were trying to communicate in an evolving landscape where things were changing. So there was by creating this and playing into the false dichotomies, it's not a zero-sum game. It's either me or you. It's I do, my independent streak, I take care of myself, but I don't worry about you. That narrative, I think, was very ineffective. And the narrative of what do we have to do to get a grip on it, either full lockdowns or caution to the wind and nothing's needed, is also not the case. It is not either a global or a local problem, it's both. And there are variations in local responses, both in time and place. And as a consequence, those that are most vulnerable and often marginalized really suffered the greatest impacts, both in terms of infection and in terms of morbidity and mortality from infection, or even the ability to access the life-saving interventions, whether they be treatment or vaccination. So we really had society being ripped at the seams by revealing these tremendous problems with health justice. And I don't think we spin this as either you can have health security and protect yourself and not worry about somebody else, or you get health justice, because we really only are as safe as the weakest link. And the vulnerability of those throughout the world is going to make all of us unsafe. So I think we have to dispel these myths of these false dichotomies. The other thing that didn't help is everybody knows that this is an example of the communication rates of exchange that occur in an internet minute. And what you see here is that TikTok had the highest engagement rate per post on social media. It was more effective than all of, whether we were looking at traditional media in the Times and the Post or Wall Street Journal, or science-based media. Science revealed that Twitter was the 9th most visited website, and fake news spreaded faster than true news. I've heard something like 9 or 10 to 1 that tweets containing falsehoods were 70% more likely to be retweeted than truthful tweets. So the era of disinformation, active disinformation with malintent, or misinformation, accidental, faulty information, really, really plagued our ability to get our communication and our narrative together. Facebook, the 3rd most visited website. This misinformation on Facebook got 6 times more clicks than factual news during the 2020 election. So these are really challenging times to be facing the kind of global scenario in terms of emergence that I laid out in the beginning. We're going to need a different kind of response in order to be better prepared for the future. WHO has announced this structure for integration. And in fact, today, they've kind of moved from a COVID-specific type of response architecture proposal to an all-hazard or all-respiratory virus for pandemic threats, organisms with pandemic potential, but they all involve this central coordination with collaborative surveillance, a community protection model, clinical care and successful information sharing best practices, and widespread equitable access to countermeasures with a coordination in the center. And I think this is going to be part of the keys to moving forward. So despite our success with vaccination, this is, this is still earlier data in October of 22. So within the first year of vaccines really becoming globally available. You can see that although there was widespread distribution initially of vaccine in that beginning year, there were still major disparities, not only in high income, upper middle and lower income countries, but also if you looked at proportion of risk populations that needed to be targeted. So we know COVID had a disproportionate mortality by age dramatically, with elderly persons suffering much greater than young people. But this risk population had a very, very disparate coverage rate with vaccine, which was in fact life-saving. And same was true for healthcare worker populations, which were on the front lines. So Martin Luther King said, of all forms of inequity, injustice in healthcare, and I would say injustice in public health, is the most shocking and inhumane. And I think that just to begin to wind down on this note, global health security and global health justice they go hand in hand. It's not an either or. We must address the global health disparities issue. If we don't put health justice and health equity at the center, our health security can't actually be strong. And so we must bridge this divide. It's an imperative for our survival. We must build back a bank account of trust, which has eroded tremendously. We need to think about our systems that can move at speed and scale. There was a recent report just out in a book. I think people said we went into the pandemic, public health went into the pandemic with a 19th century architecture for a 21st century threat. And we are unfortunately at risk coming out of the pandemic, relying on that same 19th century architecture, unless we can move to speed and scale and create much more rapid innovations in our tech space, both in the data integration, diagnostics, therapeutics, and prevention. Beyond just innovating in tech, we have to innovate in our systems and platforms. They have to be interoperable. They need to be more robust. There needs to be less concern about proprietary data and more concern about data sharing, even while protecting privacy. And I would say the magic sauce, maybe the most important thing, getting back to this problem with the pandemic narrative, is we've got to be putting a lot of effort into health literacy and health education, because no matter how good your technical solutions are, if they are not compelling to create behavior change, and if people aren't educated enough to understand what's true and what's a lie, and if the truth doesn't have a higher value than the simple retweeting or passing along of misinformation that's, or disinformation that's agenda filled, we will never get the kind of behavior coordination that we need in that regard. So trust and the narrative. This is going to require us to do, as John Doerr, who I recently met and spoke to, of having a different value-driven set of metrics by which we go into it. I think some of our old metrics of defining which countries are best prepared for a pandemic and which aren't are clearly measuring the wrong things. I mean, the US has typically come on the top of these joint evaluation efforts against a whole bunch of metrics, and yet, as you saw, we certainly didn't earn the best performer title in this pandemic. We need to have our metrics reflect our values. We have to have objectives, key results, accountability, transparency, and lubricating the system with accelerants so that the incentives are to actually get these data aligned and not for people to hold on to data out of fear of competition, or even worse, actively suppress data, which would be available for the benefit of all. So like John's book, which was really designed to talk about OKRs, his next book was called Speed and Scale. And this was about an action plan for solving the climate crisis. Speed and Scale was essentially a blueprint global initiative to move leaders to act on the climate crisis. And the work focuses on education, advocacy, and solution scaling. It's an excellent book for those of you looking for a read of can we actually create an action plan for the climate. But I think the same principles that John talks about here, the same approach, measuring what matters, commensurate with our values, and approaching the crisis with a warlike footing or a sense of urgency is going to absolutely be necessary to face the era of permademics and syndemics. Finally, we have to strengthen our global health architecture. WHO has been doing a lot of work in this space with discussions around the pandemic accord, and also today's just new release of the new preparedness, readiness, preparedness, and response infrastructure, and what those kind of systems need, governance, platforms and systems, and financing structures with a center on health justice. But also, I think what's missing from this is a real commitment to a better approach to health communication, and essentially the narrative of how do we get people to build trust in science and understand the difference between truths and lies. I'm going to wrap up with one example of from our programs. We've been building for the last couple of years a CDC travelers-based genomic surveillance program. And these are some of the people that are involved in this. It's a private-public partnership between CDC, XpresCheck, and Ginkgo. Ginkgo and Concentric Bioworks is a biotech company in Boston area. XpresCheck was a set of nail spas that was built at airports and was converted to have a health focus for this project. And the Travelers Health branch in my division has been leading this effort. So it really, just as I said earlier, global testing is markedly down over 90%, asymmetrically, but still isn't getting worse. The comparison of global reporting just in the year of January 22 compared to 23, the number of days with no reporting and the number of countries that aren't reporting at all, and the delays in reporting is remarkable. We're going back into the black hole of no surveillance, and the amount of time it takes to report a case is just gotten bad, and it's getting worse. And this is just of January, it continues to get worse and worse. So people say, are we better prepared now? We should be better prepared, but I'm afraid the cycle of panic and neglect and complacency and denial is reaping its head, and we're really going back into a data vacuum or a data black hole. So in order to address that, and this is true of genomic sequencing as well as case reporting, in order to address this real decline in our awareness and going blind, and actually flying blind, as we say in the Travelers Project, we've tried to create a system that will operate voluntarily on the front lines of COVID surveillance by having XpresSpa become a clinical locus at airports for enrolling in voluntary testing, Ginkgo Bioworks for the genomics and the sequencing, and Travelers as a sentinel population for tracking emerging infections. And this has garnered a lot of media in the US. It's moved into the wastewater space, which I'll show you. But a Travelers-based genomic surveillance system could be built up not just in the US, but also as a global hub and a network to enhance early detection, not only of SARS-CoV variants, but also of all hazard or other pandemic threat viruses. It's been expanding at the number of airports. They're shown here. It's gotten a lot of press coverage. Basically, the tagline is keep COVID grounded. You swab at the airport, you get a test to take home. You scan, enroll, results are sent. People can take action on results. But also all of the tests are basically first pooled and then individually separated, deconvoluted, and put through high throughput genomic sequencing. You could go from the arrival at the flight to having a full sequence and uploaded into GISAID within 8 days. What this means is, and this is by the numbers, participation is now at 175,000. We're getting 7,000 new participants a week, and huge numbers of samples are going into the global sequence database. You can find that data in CDC's COVID data tracker. What this does, we've tracked the trends of what we find in arriving international passengers, and it mimics but precedes the data that WHO is getting on global surveillance. And it will replace the data that WHO is no longer going to be getting when countries have gone into that black hole. We can, through the whole genome sequencing, we're able to see the variants and the proportion of the variants. And basically, as the next slide will show, we are detecting emerging variants anywhere from 14 to 44 days in advance of those variants getting a foothold where they become at least 1% in our national surveillance systems, or in our real-time estimates. So we have a really early heads-up warning system of what's coming by keeping an eye on the sky, and in particular the international travelers as sentinels. We can also detect by the origins and destinations and citizenship of where the new variants are emerging across the globe by putting this system into place. And so here's a set of the variants emergence by country and by the number of sequences. It was only about a 7-day lag between getting the specimen as a positive in a positive pool and doing a full sequence variation to get a breakdown of the genomics. It's a multimodal platform. We've been testing it on Mpox and influenza in order to fill in the gaps on influenza surveillance and better designed vaccines. Many other pathogens are being queued up for a multi-pathogen platform for doing this testing, and layering this with mitigation practices can have an early warning system for spread. We are now working with a number of entities to design a global transportation hub structure that's efficient, that once you get the detection of an emerging threat, you can move, you can expand, and it's a flexible platform where you can dial up or dial down participation in a particular area of interest. The Australians did some initial studies which showed basically that you could isolate SARS-CoV-2 in wastewater from aircraft and then link the sequence back to the infected traveler. And this was a paper recently reported on their experience with 12 international flights arriving in Australia at a time where they were moving international flights, passengers into testing and wastewater testing, the blue juice essentially from the aircraft wastewater. It was very effective. We've added this and piloted successfully such a system by designing a new, essentially a midstream catch. It takes just a minute or two, very, very quickly, doesn't disrupt flow. So when an international flight lands, we attach this device right here to draw off a representative sample from the blue juice from the plane. And we are putting that through both the PCR testing and the whole genome sequencing. This is a resource page where you can find out more about the TGS system and program. But I do think that this has promise for using technology to advance our eyes in the sky, to have an early warning system and to be a heads up instead of fully reactive. So the future of pandemics, permademics, and syndemics, are we up for this challenge? I'm not sure we have a choice. If we're not, I think we're going to get whacked hard again, and probably harder. The metaphor that I want to leave you with is the concept of intra-connected, which I got from a book from a friend who I also just recently met, named Daniel Siegel, who wrote this book, Intra-Connected. And the concept is like an aspen forest, where above the ground we see individual trees, but below the ground their root system isn't completely interconnected, and they share a common DNA. And this species, the aspen forest species, is I think the oldest living organism on the planet, and well outstrips its duration and resilience compared to humans. And I think there's something that we can learn from this concept of being interconnected. As Daniel Siegel says in his book, it's not me or you, and it's not even me or we. It's actually me plus we, that gives this concept of being connected. We don't need to give up our agency or independence or individuality, but we have to become part of community. And as he said so nicely, it's A plus B equals C. We need to create societies and communities and a global commitment to agency plus belonging. A sense of belonging is the way to build a resilient community where people are safe and secure, they're soothed and seen, and they contribute to our global whole. Because we can't be fighting with each other if we're going to be prepared for the next pandemic. We need to be unified and recognize that the real threat is coming from these wily viruses. So with that, I'd like to end, and I know it didn't leave a lot of time for questions, but I'll turn it back to Danny. And the other thing I wanted to put up here is if you click this QR code, you can connect to an evaluation form for the talk. Danny, back to you.
Well, Marty, thank you so much. That was just not only informative, but extremely exciting and philosophical too. So thank you very much for sharing all this with us. While I wait for other people to answer questions online, the thing that really bothers me the most in this whole thing is the fact that I think a big problem we face as a society is people don't have a shared set of facts. Once upon a time when we were growing up, you might remember the evening news, you had three choices. You got ABC, CBS, and NBC, and maybe PBS when things got really fancy. But everybody basically kind of was playing with the same pieces of information. I guess, how can you sort of restore trust and the public health system and other institutions if everybody has sort of their own set of facts to play with?
Yeah, I think it's really hard. I think that there is an emerging science about communication in a crisis, and a lot of it starts with communication in advance of the crisis. So part of this is taking on the responsibility of health literacy and health education. We need to have more people understand how to discern, what they're reading, and if their sources are going to be in the internet, we need to be able to teach people how to really look at quality sources. We have to be trustworthy and have quality information ourselves, so that it can be trusted when we deliver it. But we also have to communicate uncertainty and risk in much better ways than we have. This idea that science is static in the middle of a rapidly evolving pandemic and that you can't change your mind is really problematic, because it's not that way. We have to be able to evolve more with what we learn, but we have to condition people to understand that this is what we know now, what we don't know, what we're doing to find out more. And the best advice we can give you in the moment is this: when circumstances change, we need to be able to adapt that advice, but you don't get a chance to pivot society that many times. We're not driving a Porsche that can turn and make rapid pivots. We're moving an entire cargo line of complicated issues, and we have to be able, one, to get buy-in from the bottom up, not top down, always top down decision making. We need to listen to the voices in communities, especially the marginalized folks who don't have the voice, and we need to be relevant. We need to take lots of things into account. We have to build our communication and our decision making not only robustly bottom up in addition to top down, but in an interconnected way. Our economic inputs and our public health inputs, our population's perception inputs, and the political perspectives have to be fused into the creation of these plans. And I'm very worried that we have now devolved into such a degree of divisiveness, certainly here, but not only here. And the tools of the divisiveness for amplifying the bots that can amplify disinformation are moving faster than our abilities. So we need to do that, and we need to employ new types of focus on quality communication. There are really good communication sources out there. I don't know if people read Caitlin Jetelina, who does a Substack publication, called Your Local Epidemiologist, but she has all the right ingredients for creating truth in a way that most people can understand, and also in a way with compassion and humanity, and trying to keep a message simple but also accurate.
I think we'll have time for one more. So this is from Wes Van Voorhis, who you may know. He
Hey,
says,
Wes.
"Marty, wonderful new ways to look at travelers. Love the blue water sampling. I think there are some other opportunities from this pandemic. What about understanding post-infection prolonged disease, long COVID? Why was the Native American population having 3 times the death rate compared with people of African ancestry?"
Yeah, no, you spot on, Wes, and shout out to you. I miss you guys and appreciate all that you offered in training me in infectious disease and launching me into my CDC career. I think that long COVID, I haven't even begun to touch long COVID because I think it's well known that post-infectious autoimmune disease, imprinting and all sorts of other things go on. There was an interesting report today by a group, not sure if they were at UW or not, that was looking at the potential pathogenesis of neurologic long COVID, which had to do with this concept of imprinting or original antigenic sin and stimulating autoimmunity. And it reminds me of our days together in the lab where we were looking at autoimmunity from T. cruzi with the flagellar antigens FL160 creating an autoimmune phenomena for cardiomyopathy and gastroparesis and Chagas disease. I think this concept is under-investigated. I think that COVID is now given us, with an infection this prominent on the planet, has given us an entire new look on this concept of autoimmunity and what role it may be playing in long COVID. It truly is an opportunity for huge amounts of extra research. As far as Native Americans, they were at greater risk of exposure and greater vulnerability because of comorbidities to the consequences of COVID infection, of SARS-CoV-2 infection. So they were both more likely to be infected and more likely to suffer bad outcomes as a result of comorbidities. But whether there's also another propensity for long COVID in different groups still remains to be determined.
Okay, I have to give one more. This is just it's irresistible. This is from Erica Johnman in the department. The podcast Reveal did a whole story on how vulnerable CDC was to political forces at the very top that wouldn't let the CDC do the COVID case tracking as the pandemic took off. What can the CDC do to act more independently in the future and resist political influence?
I wish I had that answer. All I could say is that first year of the pandemic was one of the most difficult years in my professional career. It was really, really, I'd not experienced anything like it. Solutions, there are a lot of people writing about solutions, and like everything else, some of them have them, doing a lot of finger pointing and saying CDC really dropped the ball, wasn't up for the task. It's not an either or thing either. We made some mistakes, but it was a very, very difficult climate for public health to operate in, given the politics and given the tremendous neglect of public health infrastructure that had gone on for decades and investments. You can't expect to take away the budgets of an agency for 3 decades running and then suddenly feel like it's completely prepared to operationalize one of the most devastating pandemics in human history.
Yeah, thanks. I think that's a whole other grand round. So
Yeah.
Anyways, I want to thank Marty Cetron for joining us from New Hampshire, and hope to see you again soon in the future in person in 3 dimensions. Thanks everybody for attending. This was a great talk. I really appreciate it.
Thank you all for inviting me. It's great to be back with the UW crowd.
All right, you take care.